Well, good morning again, colleagues, and welcome to session 3 of module 3 of our AU3S Smart Safety Surveillance Capacity Strengthening sessions. Today we are moving on in the benefit risk assessment area to the subject of periodic safety update reports, or PSURs. And once again, we're going to be joined by Alison Banner-Simpson, Benefit Risk Assessor in the MHRA team. You should already be familiar with the Zoom functionality, but as a reminder to colleagues, perhaps this is your first live session. We only use the chat box function to raise questions around technical problems that you might be experiencing. I know some people also use it to introduce themselves to colleagues, and that's very much encouraged as well. But for questions for the panelists, please use the Q&A function. We often see participants raise their hands. Unfortunately, we're not able to respond to raised hands, and again would ask that you just use the Q&A function. We will always have plenty of time, we hope, at the end of the sessions to go through all of the questions that have been posted in that Q&A box. Next slide, please. So again, and as always, we're joined by colleagues across the African Union, primarily from the 4 countries that we're most actively working with at the moment, those being Ethiopia, Ghana, South Africa, and Nigeria. And other stakeholders are more than welcome to attend these sessions. Next slide, please. So as mentioned, we are in module 3, risk benefit assessment, or benefit risk assessment. We are on the 3rd session of module 3, PSURs today. And next week, we conclude module 3 with a look at the role of pharmacoepidemiology in pharmacovigilance and regulatory decision making. And then in April, dates yet to be confirmed, we will move on to the subject of safety communication. And then in May, again, dates to be confirmed, we'll look at the role of national safety committees and acquiring expert advice to inform pharmacovigilance decisions. Next slide, please. So yes, this is the direction of travel we've had with module 3, and as mentioned, make a note for your diary. Session 4 brings a close to the subject of benefit risk assessment, and that will be held next week on the 30th, next Tuesday morning. Our aims are to provide that high-level overview of how risk assessment is carried out. That was covered in session 1. Then we looked at the risk management plan and risk minimization measures with particular focus on vaccines. Today, we are looking at key principles in PSURs, and then, as mentioned, next week, the role of pharmacoepidemiology, looking at different data sources and understanding how that can inform different regulatory options. So without further ado then, if we move on to the next slide, Ali, I will hand over to you to take us through PSURs, and I'll see you again at the Q&A session at the end. And hopefully, colleagues, please do use that Q&A box to put any questions you have, both to Alison and myself, and we'll pick them up at the end. Thanks, Ali. Over to you.
Thank you, Mick. I'll just bear with me 1 second and I'll just share my screen with you. Here we are. Can you see that?
Yep, that's up.
That's up. Okay. Yep. Lovely. Okay, well, good morning, everybody. My name is Ali Banner-Simpson, and I'm speaking to you from London in the UK, and I hope you're all well. I'd like to thank you for taking your time to be here today. So I will present the key principles of PSUR. Just let me 1 second. Over here. So I'm just going to stop sharing my video so that I can see my notes. That's great. Thank you very much. Okay, so I'm going to talk to you today about the key principles and approaches to assessment of periodic safety update reports. For ease, I will use the abbreviation PSUR throughout the presentation, and this of course also refers to PBER, PBRER, the Periodic Benefit Risk Evaluation Report, which is essentially an interchangeable term that reflects the emphasis that we assess also benefit as well as risk, and this is from the E2C revision 2 of the ICH guideline, ICH being the International Council for Harmonization of Technical Requirements for Pharmaceuticals for Human Use. So without further ado, let's put it into context. As we know, clinical trials are not designed to fully evaluate safety. There are limitations in terms of the scope of the study population, how many patients are involved, and the duration of treatment, and of course exclusion of at-risk groups in the very controlled setting of a clinical trial. As we know, often it's efficacy being the primary objective of the company rather than safety, which is the emphasis. So use in routine clinical practice is likely to be different and highlight new potential safety concerns. For instance, after long-term use, we may be able to identify rare events which clinical powers are not powered to detect, or events with long latency, which come across very slowly, such as carcinomas. Also, use in different populations to those with the studies will highlight different issues, particularly in pediatrics or in pregnancy, or indeed in older populations who have complex comorbidities. Of course, how a product will be misused or abused in real life is also not known until the drug is widely available and further information is known about the benefit and risks of the product. So PSURs are one of the tools that we have to examine how use of the drug in the real world can impact on safety and efficacy. So the main objective of a PSUR is to establish the new emerging information which is seen in what we already know about the risks and benefits of the product. So a PSUR can be a standalone document, but is primarily seen in perspective to previous clinical trial data and previous PSUR reports. A high quality assessment report is, the cornerstone of regulatory decision making, and it can enable positive public health outcomes, which I guess is another way of saying that monitoring of the continual safety of a product is important to engender trust and confidence in drug and vaccine products and in our healthcare systems in general. So as you can see, the PSUR presents a lot of data and a very large structured document. Here they're color coded for a little bit of ease of interpretation. So the areas here in blue really are involved with the characterization of the product. So we have the introduction, in which you learn a little bit about the pharmacology and the indications of the particular drug substance, marketing authorization status, where the drug is authorized, dates of approval, regulatory actions taken for safety reasons by the marketing authorization holder or by other regulatory authorities. There are also updates to safety information which may relate to new contraindications or warnings or serious adverse drug reactions, or maybe on interactions with other medications. Also, it might be findings from other ongoing clinical trials, which has led to changes in the reference safety information. We're also presented with an idea of the exposure of the drug. The MAH provides an estimate of the size and nature of the population exposed, and usually this is based on the bulk of products sold. So the data presented in the yellow section, sections 6 to 14, gives us information from various different sources, information from post-marketing, for instance, all the reported adverse drug event reports, which are supported by summary tabulations of that data in the appendices. We have studies and published literature, safety findings outlined, potential lack of efficacy, and information from other sources and potentially important safety findings which have occurred since the data lock point. All those are outlined in the yellow section. The sections in green relate to risk evaluation. So 15 to 17, what is known about the important identified and potential risks at the beginning of the reporting interval. And there is also discussion of new, ongoing or closed signals and new information relating to these risks. So this is obviously a key section and can be very useful as a reference point if you identify any new signals outside of this process. If you have a PSUR, the latest PSUR, it's always useful to look here to find out if the issue that you're looking at has been discussed before and to what extent the evidence has been gathered with regard to this, or whether indeed this isn't completely a new issue. So it's a useful reference point apart from anything else. In brown, we have an overall appraisal of the benefit risk of the product as used in clinical practice. And it is considered what the implications of the new information is on the overall benefit risk of each indication here. So the MAH, or the marketing authorization holder, assesses the need for changes to product information in RMP and concludes those actions here. And also there's an area in grey where there is quite extensive annexes. You'll find the summary data tabulations, which I previously referred to, and regional appendices also of evaluations that are relevant only to one region that have become available during the reporting period. So conduction of the assessment, as you can see, can be a bit of a mammoth task. It's quite lengthy, there's a lot of information, it can be quite daunting and time consuming. So it certainly helps to base yourself within a sort of aspect of trying to become familiar with your product. You may be familiar with it already, but it's useful to read the PSUR all the way through first to try and ascertain what kind of data there is and if there is new information and how difficult or complex the procedure is likely to be. But it really does help if you know your product, if you know the epidemiology of the target population and how really it works clinically within your area. The quality of data is also very important. We try to promote quality, so look at what has been submitted, and if you're aware of relevant safety information that has not been included in the PSUR by the company, then you can ask them to provide that. If the company also has not been compliant with previous regulatory requests to update product information, you can flag this at PSUR assessment as well. You can consider the strength of evidence that's been provided, and you place that in context of the life cycle of the product. So if it's very early in the life cycle, it's a very new product, there might be a smaller evidence base really in order to take action, especially if it's a more serious type drug reaction. There may need to be expert advice, of course, so factor this in time-wise when you are looking at your assessment. So the PSUR should focus on summary information and a scientific safety assessment. And the key question really is, has the risk-benefit of the balance of the product changed? Are there new risks? Are they specific to a particular indication or use of the product, and how does this affect the subpopulation that you are interested in? Indeed, is there a change in frequency or severity of a previously known risk? But key to all this and central to all this is the clinical importance. How important it is clinically, and what is this likely to do as an impact? So in terms of the report, if we sort of nail down into various sections, so the very useful section is actions taken in the reporting interval for safety reasons. So are these reflected in your local product information, and if not, why not? It may not be relevant to your area, of course, because indications do not need to be aligned between each individual country, and safety actions may be more relevant for one country than another. For example, increased hepatotoxicity in tolvaptan, which is a vasopressin antagonist in Japan, where it is indicated for liver cirrhosis, is clearly going to be a different kind of base from where in the UK we don't indicate this product for liver cirrhosis. It's much more narrowly restricted to patients with hyponatremia or with polycystic kidney disease. So looking at these, it's not always applicable, but it's very useful to see what actions have been taken in other parts of the world. For exposure and usage patterns, of course, how widely the product is used is very important. If it's a first-line treatment, or if it's a treatment for more refractory disease, that will have an implication on how you assess the safety, of course, because if the disease is more refractory, maybe this particular drug is channeled by indication to a more serious subpopulation of people in terms of comorbidity, and so the safety of it may look more extensive compared to other drugs, but it may be due to other causes. It's useful to also look at off-label use. Is use inappropriate? Is there inappropriate prescribing, perhaps, or inappropriate or misunderstanding of use by patients, which could impact on safety? So this area gives you some sort of indication from that point of view in terms of context. In terms of the data and summary tabulations, has the company provided the number of events reported or number of reports? Tables of numbers of events should not be used for signal detection generally because they lack detail. But if you see that there are lots of events reported for events that are not listed on the product information, and indeed if the company has not discussed these within the context of the report, especially for serious ADRs, we can ask the company to provide further information on this. With regard to findings from clinical trials, non-interventional studies and other sources, are there enough details for you to be clear about the findings that they have concluded? In that particular section, medication errors can be discussed, and that might be particularly important if there's a product that is delivered via a device, for example. The signal and risk evaluation, do you agree with the company's conclusions? Have they closed the signal? Are you happy that the signal has been closed and it has been fully evaluated and investigated, for example? The company should ideally annex any signal reports. So if these are not annexed, then you can ask for these. If a signal cannot be refuted, then it could be kept open and discussed in the next PSUR, or evaluated in a different procedure based on the signal's seriousness or urgency, of course. So new information relating to previously known risks I discussed in the evaluation of risks and new information section. Characterization of risks provides a cumulative assessment of each of the safety concerns. And the benefit evaluation can be brief, and usually it's updated if there's a lack of efficacy of studies challenging the established efficacy profile, and that should be discussed in this section if this is the case. With regard to the benefit risk balance, have the risk changed? There's no need really to re-establish in each PSUR that the benefit risk is positive. If there's not been a change in circumstances, then that the present situation is maintained. So for the benefit risk balance, this slide really just outlines important factors to consider when you're regarding benefit and risk, but I will let you look at these at your leisure, as we touched on this in the risk assessment talk. Just a couple of things maybe to point out, that obviously if the benefit of a drug is for a very, very serious life-threatening disease and there are not alternative treatment options, then we would likely to be more mindful that increased risk may be appropriate, especially if you can identify a specific subpopulation that you might be able to contraindicate, so that the majority of people might be able to access the treatment. So these kind of factors are good to look at. In terms of outcome, I've outlined potential outcomes for your assessment. The overall majority fall into the maintenance of the balance of benefit and risk being favourable. But of course, there are many products which are subject to updates to product information as more information on safety becomes available. Clearly, these options of suspension and revocation are much rarer, and in fact this is greyed out revocation, because that would really be taken forward in a more complex safety referral procedure rather than from a PSUR point of view. So after all that, and seeing all those kind of very extensive sections of a rather large report to assess, I just wanted to reassure you that in terms of practicality, not all PSURs will require extensive review. If a product is early in its life cycle, and risks will be uncertain, but later on in the product life cycle, an extensive review is generally not required once we've got the risks and benefits very well characterised. So we take in the UK a pragmatic approach, depending on the product, on the life cycle, and on data characteristics, and then we triage and direct our resource accordingly. So our approach is to targeted assessment. So in the first instance, there is no obligation to routinely submit PSURs from a company perspective if these products fall under certain articles of law within the EU Commission's directive. So unless there's a specific condition in the marketing authorization, generic products, i.e. copies of the brand leader, or well-established products that have been licensed for a very long time, homeopathic or traditional herbals, do not necessarily need to submit PSURs. But for generics that are maybe from biological or have additional risk minimization attached to them, they do need an assessment. But again, we may assess all those together as a single PSUR in one procedure. This is also quite a daunting task and takes quite a lot of resource. But if we have a single procedure from a generic or an established drug, and we look at the data and the safety profile appears unchanged, we decide that there's no need for a PSUR full assessment. If there's emerging data in another domain, we may reference the assessment from another regulator and take on the outcomes that they have concluded and refer them to our own population. However, if there is new national data, we would assess the PSUR nationally. So just to give you a little bit more detail on generic and well-established drugs or vaccines, if there are no new signals, if there is no changes proposed by the MAH, the marketing authorization holder, or other regulatory domains, or if there are no open signals, we produce a standard letter with a standard statement to the marketing authorization holder. And we call this the CHOP evaluation, so the change of operational control. We really like our anachronisms in the UK civil service. So yes, basically it's a shortened assessment, and we give them a letter saying with a standard statement saying, based on the review of data on safety and efficacy provided by the MAH, the risk benefit balance remains unchanged and the marketing authorization can be maintained. And so that's really very, very brief assessment. If the answers are yes to any of those questions, we revert to a triage template. And again, this is not the full PSUR template that you saw in the previous coloured slide. So if we decide that the issue is not an issue and is not really of concern, we would revert to standard statement. Or if we identified any issues that are not really fully characterised and we would like a little bit more information, we would ask the company to provide a cumulative review and address these issues in the next PSUR with more fulsome data that we can base our assessment on. Obviously, this depends on how quickly the next PSUR is due, and sometimes it wouldn't be for a long time, so that needs to be taken into considerations as well. But we also may decide that there isn't a requirement to update the product information and to provide further safety information to patients, and a variation is required for the company to do that in order to maintain the marketing authorization of the product. So a focus assessment may look a little bit like this. I hope you can see this on the slide. I know it's very, very small. You maybe have some PDF copies that you're looking at. So this is a focused assessment to concentrate on an issue only. So you can see with we look at the introduction, the worldwide marketing approval status, actions taken in the reporting interval for safety reasons, changes of reference to safety information. We give a context of exposure, use and patterns, and then we look at the actual signal in hand and then how that relates to the benefit risk. And I've included all of the modules. Of the PIVA ICH models, there is 20 plus a few sort of subheadings, but I've given those an extra slide at the end so for you to look at, so that you're clear on the whole, what the whole assessment would look like. Indeed, if you decide that you don't have enough resource, you might decide to collaborate with other members of the union. For example, you might be able to give a decision within a time period in association with another designated regulatory authority if resource does not allow time for assessment within a given time frame. And this is a potential template for taking this forward. So there are various types of periodic safety reports, and the PSUR and the PIVA is generally after the new substance submitted every 6 months for 2 rounds, and then 12 monthly, 18 monthly, 2-year, 3-year and 5 monthly intervals before the product is renewed. There are also other types of periodic safety reports, however. So we have in early access to medicines scheme in the UK for drugs with orphan indications, where emergency provision of treatment may be available to patients where they otherwise wouldn't get access to treatment. So these are usually treatments for very rare diseases or for cancers, for new innovative medicines, and they are subject to more active pharmacovigilance. So at the time that they're allowed to be rolled out to patients, there is a scientific opinion given by the MHRA to say that these products are okay to be continually to be given to patients in a more active pharmacovigilance and study environment. So in these reports, the company will state what period the report is, whether it's the first, second or third report, and what reporting period is covered, and they will describe the level of exposure during the reporting period and whether there were any new safety concerns or significant new data. And generally, because these are rolled out to a fewer amount of patients, individual ADRs and case narratives are described to allow us to see really how the treatment protocol is working and whether the risk management plan requires updating. So in all, we decide whether the benefit risk remains positive to continue the EAMS criteria. In addition to that, we have the summary monthly safety reports for vaccines, and these would be for the new SARS-CoV-2 vaccines. And the periods would be monthly, 3 monthly, 6 monthly, 12 monthly, or 18 monthly. But at the moment, of course, this is all very new still, and so we are receiving monthly summary safety reports for vaccines in the UK. So again, there's lots of information that is submitted here, and we need to be able to assess them efficiently. So we have another CHOP evaluation type approach. So we look at the company perspective. From their perspective, is there any action proposed in this new site safety update? Are there any happenings of significance, for instance? From our perspective, from the regulatory perspective, is there any action ongoing or indeed required? And are we satisfied with the product information? So if the answer to all the questions 1 to 4 is no, then no further assessment is necessary. But if the answer is yes, then we promote some actions arriving. We may review a particular issue or issues, and we outline them and then focus the assessment on these particular aspects. We wouldn't really do a full benefit risk review unless there were major or multiple concerns. And within each assessment, of course, we look at quality. So we feed back to the company whether the PSUR was adequate or whether we need more information in various aspects of the data. So in coming to decisions about the risk-benefit balance, which is obviously the idea of the PSUR itself, if there are uncertainties which arise over the risk-benefit balance, we need to keep in mind the likely impact. Expert clinicians and healthcare professionals in the field may highlight aspects that we haven't considered. And we try to look to this and consider whether we have really got the key messages. What key messages are important? What do we need to know about the risk before we consider what risk minimization options would be appropriate? Are there other data sources that we might tap into to help us formulate a decision? Knowledge of clinical guidelines will allow estimation of an impact of a decision to patients. So all these things we try and bear in mind. And of course, I think if you've attended the previous lecture on risk assessment, you will know that communication is the key, and the output of what we do, we need to get to the patients and the healthcare professionals who are prescribing and administering the drugs to make sure that the safety message really has got through to who it needs to get through to. And then further down the line, we need to evaluate how effective we've actually been in mitigating safety for the patients. So at this point, I have some examples. I'm not sure how I'm doing time-wise. If you want me to carry on with some examples before going on to the discussion.
Yeah, Ali, you've got plenty of time, so I think the examples would be really useful. Thanks. Okay,
thank you. Yeah, I think the examples are quite nice. It helps you kind of look at. I've just taken a couple of things here from the EU and UK. As you know, until January of this year, we were working in association with the EMA for all our procedures, really, pretty much. So the first one I'm going to discuss is Finasteride and rare reports of depression, suicidal thoughts. And the second one is an antiretroviral drug, darunavir and sobisistat. I hope I pronounced that right, I probably haven't. And the treatment failure and increased risk to mother-to-child transmission of HIV during the 2nd and 3rd trimesters of pregnancy. So, okay, so I'll move to Finasteride. So I'm not sure whether you'd be familiar with Finasteride or not. Finasteride is a 5-alpha reductase inhibitor and is used in benign prostatic hyperplasia, so enlarged prostates in men, generally from middle age onwards, more in the elderly population. So finasteride kind of has a mechanism of action which shrinks the prostate by preventing hormonal changes that cause prostate growth. And of course, if the prostate growth is in evidence, then we have problems of urinary retention potentially, and urinary tract infection, and renal renal damage from renal infections too. So this drug has been licensed from the 1990s, has been very effective in reducing prostate size in elderly men. But it's also indicated in younger men, in the younger population, with male pattern hair loss at a dose which is much less, at 1 milligram. The depression was recognised for the 5 milligram dose, but it was not recognised for the 1 milligram dose. So we became aware of some evidence that potentially there was an issue. So we raised it at a PSUR level with the company and asked them to discuss whether finasteride and depression was in evidence for finasteride 1 milligram. So looking at our signal database, we saw that in general, there was disproportionality. The BGM was 2.884, which is over our threshold of 2.55, and the EBO5 was also raised over our threshold. We also looked at another wider term of mood alteration with depressive symptoms, and that also showed increase in disproportionality of events. So then we honed down from a wider terms to the preferred terms, which were singular terms, to see whether there was in fact an issue with depression and the 1 milligram dose. So for depression itself, for the drug in general, there were 21 reports. That could be for propecia or for prostaglandin indicators, because it's the same drug substance. So we had 21 reports of that. For Proscar, for which it is listed, there were 14 reports, but for propecia there was double the amount of reports for that, there were 28. We also noted that in terms of suicidal depression, there were also 3 reports for the 1 milligram dose. We also widened our search a little bit more and saw that there were issues also with decreased interest and with depressed mood. So in the post-marketing setting, we saw that these issues with depression were also usually reported in combination with other events such as erectile dysfunction. Erectile dysfunction is a listed event for this drug, and of course with the elder population this might be seen differently or treated differently than with a younger population of males in their 20s. So depression did appear to be associated with erectile dysfunction as a secondary effect. The company pointed out there was no evidence seen in controlled trials, but of course the trials are not powered to see these rare events, and there was no concentration on whether depression occurred. So we rejected their sort of assertions that this couldn't be possibly the case because it wasn't identified in trials. The company also said that really they didn't really know whether there was much of a temporal relationship. But of course, where there's a slow latency of depression in terms of it coming on and gradual onset, also this can't be depended on to in fact say that there isn't an issue. So we asked the company to provide us more evidence, to give us more detail, and to do some more cumulative reviews about our the post-marketing events they had received. So looking at the qualitative evidence, we saw that there was actually a temporal association with many of the cases. And in some of the cases, we had evidence of de-challenge. So when the patients stopped taking the drug, gradually their depression got better. And of course, there were other patients who decided that at some later point, they would retake the drug because they were worried about their hair loss, and then they got a re-challenge in that they experienced depression very soon afterwards. So we had some evidence from that point of view. We looked at prior history and saw and investigated whether we thought that patients who had a prior history of depression were more susceptible. We didn't see a lot of evidence for this, but we did see that some patients definitely with a prior history of depression did experience this when they took finasteride 1 milligram. As I mentioned before, there did seem to be a possible relationship to erectile dysfunction, and in some patients, indeed, erectile dysfunction can persist after the drug has stopped, and so this would, of course, lead to secondary effects of depression in many cases. So, looking also at the preclinical evidence, we noted that there was some evidence that finasteride crosses the blood-brain barrier, so there may be a mechanism for causality. And when it was quite a tricky situation, but we thought overall, despite the absence of evidence from the other data sources such as clinical trials, that there was sufficient evidence to suspect a causal relationship in this case. And we urged the company to update their product information. We just considered this important. So on the summary of product characteristics for healthcare professionals, there was a warning that was added, which included depression and less frequently suicidal ideation, and that patients should be monitored for psychiatric symptoms if these occur, and that the treatment should be discontinued and the patient advised to seek medical advice. In the side effects section, depression was noted with a caveat that it has not been seen in clinical trials, but has been seen in post-marketing use. On the actual product information for patients, there was a warning saying that mood alterations such as depression and suicidal thoughts in relation to this same one here, and that was outlined. The patient should stop taking the treatment straight away. So this differs from Proscar, which already had depression and a label, but in that particular case, for the 5 milligram dose, we don't advise patients to stop taking straight away because obviously there could be consequences in terms of their prostatic disease. So, but for this milder indication, non-serious indication, we advise patients to stop taking Propecia straight away. And in the side effects section, so it's more relevant to patients, we said please stop taking Propecia and talk to your doctor if you feel symptoms of depressions or feeling of severe sadness and unworthiness, because this is what has been described in some of the case narratives by patients. So we decided to relate that specifically for patients. So the take-home message from this rather prolonged assessment that was initiated by the PSUR was sometimes the assessment is based largely on one data source and it can't be dismissed on the basis that it isn't seen in more than one data source. It is useful to look at all the relevant spontaneous ADR cases and more wider terms, not just in one specific preferred term. Important to consider the qualitative and the quantitative evidence to assess a possible causality, and also to consider proportionate warnings, taking the indication into account. So there were differences in the way warnings were outlined in the different indications. So that was the example for finasteride. I think I'll go on to one on darunavir in virologic suppression in pregnancy. As you will know, it's a protease inhibitor and it's co-administered with low-dose ritonavir and indicated in combination with other antiretroviral medicinal products for the treatment of patients with HIV. It's indicated from children from 3 years upwards from a 15 kilogram body weight. So within a PSUR procedure, a additional pharmacovigilance study was reported on, and it concerned a study in pregnancy and postpartum use of darunavir. Initially, the trial was to concern 36 patients, but there was an issue in getting enough patients to participate in the trial and or indeed to keep in the trial without dropping out of the trial. So in the end, it just contains information regarding 6 pregnant women during their 2nd and 3rd trimester. And what was found in the study was that the mean darunavir concentrations were around 90% lower during the 2nd and 3rd trimesters of pregnancy as compared to postpartum, and exposure of So Bicistat was 63% and 49% lower during the second and third trimesters of pregnancy, respectively, as compared to postpartum. So these low exposure values seen in these two drugs during pregnancy are a reason to strongly recommend against the use of that combination during pregnancy. And indeed, when the company received these results, they were very quick to say, look, we need to act on this. As you can see, it's based on very limited data. Only 6 patients completed the trial, but what was very striking was it was very consistent between those 6 patients. A further extension saw that the twice daily regimen appeared to be a bit more effective, but the main overlying message was that this may result in HIV transmission to the child, and hence the product should be not recommended in this part of pregnancy. So the outcomes were that product information was changed for all products containing darunavir. So we have Prezista, Resolsta, and Simtusa. All of them, as you can see in the title, contain various darunavir with various different combinations of other antiretrovirals. And the conclusion was that therapy should not be initiated during pregnancy with anything containing darunavir and Bicistat. So women who became pregnant during therapy with darunavir and Bicistat should be switched to an alternative regimen. And that could be with ritonavir, because with ritonavir seemed to be a little bit more effective. And this is because the pharmacokinetic data showed low exposure values of darunavir and Bicistat during the second and third trimesters. And it might be associated with increased risk of mother-to-child transmission of HIV. To reinforce this message, a direct healthcare professional communication was also distributed. And within our specific organisation on the MHRA, on our website, we published a report of this on the drug safety update, and we alerted health professionals via that means as well. So I've come to the end of my presentation. There are some additional resources which I think you might find very, very useful. On the EMA website, for instance, not only do you have guidelines on the good pharmacovigilance practice modules of PSURs, there are questions and answers about PSURs, which are very useful. And there are templates as well for assessments, which have keys in green of things that you might consider for each section. So thank you very much. I'd just like to say, I'll try and answer any questions in the thing. I don't know if there's going to be other sessions which will help you a little bit more, but let's look at some questions and answers now.
Thanks, Ali.
Stop sharing my screen.
Well, maybe keep it up there for a little while, Ali, because I think that there's been a question or 3 questions coming from Malaku Mekanen from Ethiopia. Yeah. Maybe worth going back to a couple of your slides. So
okay, sure.
The first question was what information must be included on the PSUR. I think your slide 13 covers that quite nicely. So it might be worth just going, talking to that slide a little bit around the information that needs to be included.
Sorry, I'm a little bit delayed on the... So I think maybe this slide are we talking about?
I've got a nice, there we go, this one.
Yes, I think with all the colours. So yeah, actually at the end of the slide deck, all these sections which are outlined in the colours here, I've put on a kind of like of 3 separate slides, like on Excel sheet to show you each of the various sections. So this is everything that the company will submit as their submission, they have to cover all these sections. So that's what they do. So they give us data on all these things. And the targeted assessment is when we just, you know, home down into various sections. And so the idea of the ICH guideline is that you can take modules from each section according to how the product is in the life cycle. And so for instance, for a new drug substance, we would assess all these sections in detail. And it's only when a product is more established that we just hone down to just one or two sections. I hope that answers the question.
Yeah, I think so. Is there a rationale to the color coding on this slide?
No, that's actually, sorry, the color coding is just so the first 5 are really product characterization. The yellow ones are more concerned with the data which has been submitted, and then the green ones are the benefit risk evaluations really and what we know about the product, and then we have conclusions and actions in the brown sections. So that's just really just to help you show that they are sort of slightly different and demarked, but in the assessment itself you will just see these just they won't be color coded as such, just to demonstrate on the slide.
So then Malaku's next question kind of followed on from your comment there around where a product is in the life cycle will determine what's included or what you focus in on. And then the next question was around submission requirements, and I think slide 28 you cover the frequency requirements, and obviously these the frequency lessens according to age. And I just want to go over that a little bit.
Yeah, hang on, that's that, isn't it? Yeah, so when we have a new drug substance, the frequency would be 6 months for a periodic safety update report for a general full marketing authorization. So the 6 months they submit, then they submit another one at 6 months, and then if the safety seems to be okay, then we'll carry on with a 12 monthly submission, then 18 months, then 2 years. I mean, it depends on the area that you're in, whether you how frequently you want them to be submitted. I think it depending on areas of the world, they change a little bit more. So I think when there's less resource, I think there are less PSURs submitted in general, but in the UK we have 2 6-monthly reports followed by 12 monthly, 18 monthly, 2 years, and then 3 years, and then we start looking at renewals and less frequent PSUR submissions. And it's really at the point at the end of the spectrum where we would do a targeted assessment, whereas in the beginning we would do a full PSUR assessment.
So that segues very nicely into the final part of Malaku's question, which is around what procedures should be followed for the assessment of a PSUR. And I think that's very much determined by where it is in the product life cycle, is it not?
Yes, and so I think what if I go, let me see which one, in terms of this change of operational control here, the questions that we ask on this triage slide, the questions that we ask on the triage slide will depend on where we are. No, that's for the vaccine. It will depend on whereabouts we are in the product life cycle. So if you see there are generic and well-established use, they might not even need to submit their PSUR. If they do, we would not really look at it unless there was a specific safety issue. But for a new or active, they're required within six months, and that's when we would start assessing it. But in some areas of the world, then assessment is done in conjunction with another network member, and the outcomes of someone's report would be taken on by that particular state. This is a reduced assessment here, just to focus on one specific issue with something that was generally well characterized.
So we have a frequency that's often determined at the time of licensing as to when the next PSUR comes in. I think there's two ends to the spectrum here. So you mentioned with the COVID vaccines, data's coming in much more frequently from
every month,
from those manufacturers. Is that in the PSUR format?
Yeah, so it is. It's a quite extensive format, but in terms of our assessment, we hone down into the questions of whether there's extra things that we want to do, and then we concentrate it, because it's impossible to be able to get that amount of data in and have look. So that you need to hone down into what the issues are. Are there any new issues? And so that's the way we manage to assess it. And then if there are lots of issues, then we would do the full assessment. Yeah, so we do have an overview. It's not that we don't look at it, it's that we don't actually do a written output for every single section. So, with all of them, you would look at the data and see what there was, but you wouldn't necessarily do a written output. So if it was something that looked very safe, then we would do that standard statement saying that we don't perceive that there's any difference in risk-benefit balance. I mean, there might be an opportunity in further sessions to outline how to actually conduct a PSUR assessment. This was mainly meant to be an overview, but we do have other sessions that we can do where we can go down section by section, the sort of things that you would write in your assessment for each section. And as I say, the EMA template, which is available on the EMA website, gives you a template for assessors, and then under each section it gives an area in green of what sort of things you could consider in the data that you're looking at. And it's actually very, very useful in terms of going through. And there was another project as well called Scope, in which they looked at. It looks like I've broken up. Hello? Yes, and there was a Scope project too, in which assessment was looked at very closely throughout the whole European region, so that we could try and make sure that people were looking at things in a very sort of concentrated and consistent way across all member states. So that's also very useful in terms of teaching materials.
I wonder, Ali, I think it'd be useful if we could put the links to that material in the follow-up, where I think Mercedes will always point people towards the recorded versions. So we could provide some of those links possibly to the EMA's website. These are open access materials. Yes,
exactly. I mean, they're on the slide, but we could actually provide them in the email maybe, which would be much more helpful. People could just click on. So yes, I certainly could do that, because they are absolutely very, very helpful.
Yeah. Okay, great. So colleagues, please put any further questions. I hope, Malaku, though, that answered your set of questions. I haven't seen any further comments coming in from participants. So in the absence of that, perhaps we could go to the poll, Mercedes, that we always ask participants to complete.
Shall I stop sharing my screen now, Mick?
Yeah. Thanks, Sally. So whilst the poll's being completed, Ali would like to thank you for your sharing your expertise this morning around the PSUR. For colleagues, as always, these sessions are recorded. They're available. We encourage you to share with colleagues that were unable to attend. And if you have any questions that you haven't raised this morning that come up in reflection, feel free to pop them on an email to the AU3S team, and we'll pick up afterwards. So Ali, once again, thanks very much, and thank you everyone for joining this morning. Goodbye.